Welcome everyone. Today we are discussing acute traumatic spinal cord injury, a condition that has become a global epidemic in our modern society. To put this into perspective, in the United States alone, there are over 17,900 new cases every single year, and nearly 3 million people are currently living with the long-term effects of this devastating injury. The leading cause is motor vehicle accidents, accounting for nearly half of all cases. This is followed by falls at 16%, acts of violence including gunshot wounds at 12%, and sports-related accidents at 10%. Despite the significant medical advances we've made in understanding how these injuries develop and improving early recognition, TSCI remains a catastrophic event that frequently results in permanent and severe disability. In this presentation, we will explore the epidemiology, pathophysiology, clinical presentation, and current management principles for this challenging condition. Historically, spinal cord injuries were viewed with immense pessimism. The earliest clinical account, found in the ancient Egyptian Edwin Smith papyrus, starkly described it as a disease that cannot be treated. Later, figures like Hippocrates advocated for reducing chronic spinal deformities, and Galen conducted experiments to localize injuries. However, a truly gloomy prognosis persisted until the end of World War II. A major turning point occurred in 1944 when Sir Ludwig Guttmann founded the Spinal Injury Centre at Stoke Mandeville Hospital in England. This was the first centre dedicated to the comprehensive global care of patients with spinal cord injuries. Following this, the Veteran Administration in the US initiated similar services, fundamentally shifting the focus toward patient education, early diagnosis, aggressive treatment of complications, and robust physical and occupational rehabilitation. Understanding the pathophysiology of spinal cord injury requires distinguishing between primary and secondary injuries. The primary injury is the immediate mechanical insult, typically a direct compression, tearing, or disruption of the spinal cord resulting from impact to the vertebral column. This initial physical damage is currently irreversible. However, this primary event triggers a complex secondary cascade of injuries. Over the following hours and days, processes such as ischemia, severe inflammation, breakdown of the blood-spinal cord barrier, and disrupted cellular homeostasis occur. Additionally, programmed cell death or apoptosis further exacerbates tissue loss. It is crucial to note that at present, there are no medical treatments that can effectively reverse the acute spinal cord injury itself, making the management of the secondary cascade and, most importantly, prevention our primary clinical focuses. When a patient presents with an acute traumatic spinal cord injury, the clinical picture depends heavily on the level and severity of the lesion. Nearly half of all these injuries involve the cervical spine, typically resulting in varying degrees of quadriparesis or complete quadriplegia. To standardize the assessment of these patients globally, we use the American Spinal Injury Association, or ISIA, Impairment Scale. First issued in 1992, this scale evaluates motor function, sensation, and crucially, bowel and bladder control mediated by the S4 and S5 sacral segments. The presence or absence of function in these lowest sacral segments is the defining factor in determining whether an injury is complete or incomplete. The scale ranges from A, indicating a complete injury, to E, indicating normal motor and sensory function. Let's break down the ASIA scale categories. ASIA A represents a complete spinal cord injury, meaning there is absolutely no motor or sensory function preserved in the lowest sacral segments, S4 and S5. ASIA B is an incomplete injury where sensation is preserved below the neurologic level, including the sacral segments, but there is no motor function. ASIA C is also incomplete. Here, Motor function is preserved, but more than half of the key muscles below the neurologic level have a muscle grade of less than 3, meaning they cannot move against gravity. ASIA D is an incomplete injury where at least half of the key muscles below the level have a grade of 3 or more, indicating active movement against gravity. Finally, ASIA E indicates normal motor and sensory scores, though the patient may still have sustained a spinal cord injury with other neurological signs. Beyond complete and incomplete designations, specific clinical syndromes frequently emerge based on the anatomical pattern of the injury. Central cord syndrome is typically seen after mild trauma with concurrent cervical spondylosis. It is characterized by disproportionately greater motor impairment in the upper extremities compared to the lower extremities. Brown-Séquard syndrome results from a functional hemisection of the cord, often from penetrating trauma. It presents with ipsilateral loss of motor function and proprioception, alongside contralateral loss of pain and temperature sensation. Anterior cord syndrome involves direct injury to the anterior two-thirds of the cord, affecting the spinothalamic and corticospinal tracts. Patients lose motor function, pain, and temperature sensation, but because the posterior columns are spared, they retain proprioception and vibration sense. Continuing with clinical syndromes, cervical cord neuropraxia, or transient quadriparesis, is often seen in athletes following axial loading injuries. It acts like a concussion of the spinal cord with temporary symptoms. Conus medullaris syndrome involves injury to the terminal end of the spinal cord. It presents with a mix of upper and lower motor neuron signs, and significant sphincter dysfunction is prominent. Finally, Cauda equina syndrome involves injury to the lumbosacral nerve roots below the conus. It is a lower motor neuron lesion characterized by severe radicular pain, saddle, anesthesia, varying degrees of paraplegia, absent reflexes, and profound bowel, bladder, and sexual dysfunction. Recognizing these distinct patterns is vital for accurate diagnosis and prognostication. Discussing prognosis is challenging but necessary. Historically, early death following acute traumatic cord injury range from 5% to 25%. When looking at neurologic recovery, there is a stark difference between complete and incomplete injuries. For complete injuries, only about 11% of patients will improve by at least one ASIA grade, and less than 3% will regain useful motor function. Late conversion from complete to incomplete is rare, occurring in only 4% to 10% of cases. Conversely, incomplete injuries have a significantly better prognosis, with upper extremity motor recovery being almost twice as great as in complete quadriplegia. The timeline for recovery is also predictable. The vast majority of motor strength improvement occurs during the first 6 months after the injury, with smaller gains continuing into the second year. Medical comorbidities heavily influence outcomes in spinal cord injury. Cardiovascular complications are particularly prominent in injuries above the T6 level due to the disruption of descending sympathetic pathways. This loss of sympathetic tone leads to neurogenic shock, characterized by hypotension from decreased vasoconstriction and venous pooling, and bradycardia from unopposed parasympathetic vagal input. Another critical life-threatening complication is autonomic dysreflexia, which manifests as severe hypertension, headache, and flushing above the injury level in response to noxious stimuli below the level. Furthermore, due to muscle paralysis, venous stasis, and a transient hypercoagulable state, these patients are at an exceptionally high risk for developing deep venous thrombosis and subsequent pulmonary emboli. While cardiovascular issues are severe, cardiopulmonary complications remain the major cause of death in acute spinal cord injury patients. Respiratory failure, pulmonary edema, and pneumonia are incredibly frequent, occurring in up to 84% of patients with high cervical injuries due to the loss of phrenic nerve and intercostal muscle innervation. Beyond the cardiopulmonary systems, patients face numerous other challenges. Gastrointestinal complications like acute stress ulceration and paralytic ileus are common in the acute phase. The integumentary system is at constant risk for pressure ulcers due to prolonged immobility and lack of sensation. Finally, we must not overlook the profound psychological impact. Depression and severe adjustment disorders are highly prevalent, necessitating a comprehensive, multidisciplinary approach to patient care. When a patient with a suspected spinal cord injury arrives, management begins with standard trauma protocols: airway, breathing, circulation, and disability. Crucially, strict spinal immobilization must be maintained until severe instability is definitively ruled out. For diagnostic imaging, plain radiographs are standard, but advanced imaging is essential. High-resolution CT scanning with multiplanar reconstruction is the superior modality for evaluating the bony architecture, identifying fractures, and measuring canal encroachment. However, magnetic resonance imaging, or MRI, is the absolute gold standard for visualizing soft tissue injuries. MRI allows us to see spinal cord compression, edema, contusions, and intraparenchymal hemorrhage. These MRI findings are not just diagnostic, they are critical for determining the prognosis, as the presence of hemorrhage generally predicts a worse outcome. The medical management of acute spinal cord injury has evolved significantly, particularly regarding the use of corticosteroids. Historically, based on the National Acute Spinal Cord Injury Study, or NASCS trials, high-dose methylprednisolone was the standard of care if administered within 8 hours of injury. However, subsequent analysis revealed that the modest transient neurological benefits were vastly outweighed by severe complications. High doses of steroids were associated with significantly higher incidences of severe pneumonia, sepsis, and death. Consequently, current guidelines from major neurosurgical societies state that glucocorticoids are no longer recommended as a standard of care. Instead, medical management focuses on aggressive hemodynamic support, specifically augmenting the mean arterial pressure to greater than 85 millimeters of mercury to ensure adequate perfusion to the injured spinal cord. Surgical intervention plays a critical role in managing traumatic spinal cord injuries. The primary indications for surgery include proven spinal instability, progressive neurological deficits, and ongoing extrinsic compression of the spinal cord. The goals are straightforward: surgically decompress the neural elements and realign and stabilize the spinal column to facilitate early mobilization. A major point of discussion is the timing of surgery. The landmark STASIS trial demonstrated that early surgical decompression performed within 24 hours of the injury resulted in odds of significant neurological improvement that were 2.8 times higher compared to late surgery without increasing complication rates. To standardize surgical decision-making, we utilize specific scoring systems such as the subaxial cervical and thoracolumbar spine injury classification systems, which weigh morphology, ligamentous integrity, and neurological status. Following acute management, early and aggressive rehabilitation is paramount. Initiating rehab quickly takes advantage of the nervous system's heightened plasticity after an insult. The field of restorative neurology focuses on maximizing residual function by carefully managing spasticity and augmenting sensory inputs and motor outputs. Looking to the future, several exciting experimental therapies are under investigation. Epidural spinal cord stimulation has shown remarkable promise in restoring voluntary movement in chronically paralyzed patients by modulating spinal circuitry. Pharmacologically, neuroprotective agents like riluzole are currently in clinical trials to assess their ability to limit secondary injury. Furthermore, stem cell transplantation utilizing mesenchymal or stromal cells offers potential for trophic support and remyelination. While these remain experimental, they represent significant hope for fundamentally altering the prognosis of spinal cord injuries in the future. In conclusion, acute traumatic spinal cord injury remains a devastating, life-altering event characterized by a complex primary mechanical insult followed by a destructive secondary biochemical cascade. Managing these patients requires a highly coordinated, multidisciplinary approach spanning acute medical stabilization, timely surgical decompression, and rigorous long-term rehabilitation. However, because we still lack any medical treatment that can cure or reverse the initial neural destruction, prevention remains unequivocally our most effective management strategy. Public health initiatives focusing on traffic safety, the strict use of seat belts and airbags, fall prevention, and violence reduction have proven successful in lowering catastrophic injury rates. Continued education and vigilant safety practices are essential to combat this global epidemic. Thank you for your attention.